In this video, we're going to use Dawn as the model to cover SI joint anatomy, as well as cover a few myths and ways to manage pain and symptoms associated to an SI joint problem. So Dawn, why don't you spin around first and we'll show them the anatomy here that we're talking about. So the SI joint is one that is a connection point between, this is called the ilium, this is the keystone, which is the sacrum, and then we have another ilium here. You actually have two SI joints. There's one here, there's one here. And Dawn, does this show it in the front of this model here that you have? Oh, good. So we see them right here as well. So what we don't have in this model is all of the ligaments that cover this. And if you look at an anatomy book, you'll see tons of ligaments covering both sides of the thing. It's literally encased in ligaments. It doesn't really move a ton. And then we have muscles, which we have the hip flexor, which goes in front of it. We have the iliacus. On the backside, we have the glute max, which actually crosses the SI joint. So it starts at the sacrum and it comes around and it attaches to the IT band as well as the femur. And then we have a lot more back there. And so there are other components which help stabilize the SI joint, but that's kind of it in a nutshell.
So the primary function of the SI joint is ultimately to transfer load. So we as humans, we go from just being on one foot, right? So it's going to transfer load from the limb into the trunk. It's there to help keep you stable. It's super friggin' strong.
Yeah, it's not very often that it actually falls apart unless there's trauma involved. So it requires some type of contact, some type of load, like with weightlifting, car accident, or slip and fall. There's many other reasons why people can have SI joint pain, especially with running, sprinting, twisting, racket sports, and even pregnancy. And we'll go into all those nitty-gritties today.
So typically, if you have SI joint dysfunction in some form, you're gonna feel it at the actual SI joint. So if we look at Seb here, ultimately, to locate his SI joints, we just find the top of his pelvis here, okay? We go inward with the thumbs, and you're gonna feel these little bony things on the backside here called the PSIS. That's where your SI joint is located. Usually it's gonna be tender and local to that spot there, especially when you press on it. But when in extreme cases, not even extreme cases, when it's really flared up, it can refer pain too. It can refer upward into the low back. It can come around the outside of the pelvis here. It can go down into the glute. I do believe sometimes it can refer as far as the thigh or the hamstring. Do you ever see it go past that?
I don't see it really go past the knee so much, but it seems less common as it gets further away. It's usually more localized right into the regions that you talked about first around the pelvis.
Yeah, absolutely. And because the pelvis is made up of different bones, it can kind of refer to the front side here too. So it can affect the joints around the pubic bone as well.
Yeah, usually doing an examination for it is something called Laszlo's cluster, which we're not going to do today, but it is about 5 tests and you have to have 3 of them that pop up positive. And even then it's not super specific. It can still be other things too. Imaging can be helpful, but also it's not.
This is true. It's most of the time there's your pain. We're going to go, MRI or X-ray that spot. And a lot of times you really don't find anything unless, like we said in the beginning, there was some trauma. And so we end up finding something on an X-ray that way.
Yeah, there's actually been some papers that indicate that even degeneration of the SI joint actually don't really create symptoms in most people who have it. So it really begs the question of how useful is imaging going to be? It can be helpful, but it's more to rule other things out. So there's a lot of yeah buts to this. It seems like imaging can help, but it can't. The exam is helpful, but it's not. Usually deciphering all this information takes a skilled examiner, and that's put it in pieces together. That's why people like us have jobs. So if you guys are looking for help, we have telehealth as well, or you can come visit us in Costa Mesa, California. Now let's get into those other nitty-gritties, and we'll talk about why people can have pain into the SI joint, but really don't have the trauma or the impact associated to it.
So there's different reasons why you can feel pain around the SI joint, but that not be where it's coming from. Facet joints are very much involved here. So the facet joints are a part of the spine, okay? They're a joint on the backside that usually prevent extension or extension with rotation. And so you have them on each level of the spine, but usually the ones in the lumbar spine or the low back can refer to that SI joint area.
Yeah, so there's the SI joint again. Here's the keystone. Here's the ilium, as we showed on down before. But yeah, these facets, we're going to show in some of the pictures here, the referral patterns. It actually comes around this whole area, which is very complicated because it overlaps a lot of the tissues that you may be thinking that you have problems with, like the piriformis and the SI joint. But we tend to find that people with more excessive compression at the facet joint, like those pregnancy, or overweight people, or people who just like to have a lot of lumbar extension, which also couples with anterior pelvic tilt. So if you guys been reading things about anterior pelvic tilt and all this, it's all the same thing. Like these all go together.
Yeah. Another thing that can refer pain as well is what we call discogenic pain. So it's another structure in the spine that can be involved and refer pain to that area. Usually the lowest one, L5, S1, right before it hits the sacrum there, is going to refer pain to the SI joint. You can have a disc bulge, you can have tears in that area, you can have maybe some like arthritic changes around the area, or it's starting to dry up due to age. All of that stuff can refer pain right into that joint.
Yeah, and it's like, if you guys notice that, again, there's the SI joint. Look how close this darn thing is. Like, who's to say there's not like an inflammatory party around like a disc thing, and then it just starts to creep its way over. Like it could, like
inflammatory party. That's
sometimes parties spread, depends how big they get. So, but discogenic referral is really common, and as you see in this picture that we're showing now, is that the pain in the back side of the hip, and you see all those little arrows that go around. This is all for S1, L5, L4. Like they all have this backside of the pelvis all involved, but then the distribution changes as you get further down the leg. So discogenic referral is really common and oftentimes overlooked when you're not responding to typical SI joint problems.
Totally. I actually was dealing with this myself when I was in chiro school, and I was getting my SI joint adjusted all the time, and it was helpful, very temporarily though, until we figured out it was actually coming from a disc area in the low back.
Now, did you have back pain at the same time as that?
Yeah, it felt like a tight muscle, more like a muscle spasm too.
I know a lot of people feel like that QL, or like they feel like it just kind of brought across here, but it seems like it's actually very common that it's like, if it is still from a disc, like this is a very intense spot for them. Like it's like where they feel most of their pain. And this is like an afterthought, so they don't really think of it too much.
Yeah.
The next one is the superior cluneal nerve. This one actually exits out of right around here. This is called the TL junction, thoracic and lumbar junction, and it travels amongst the skin down and it hangs out kind of around here. We have a picture here that we can show you that demonstrates where it goes and the anatomy of it. But I think the big picture is that it actually refers into the same location, but it's actually not, the symptom generating tissue is not the SI joint, it's not a disc, it's not a facet, it's actually just more of a nerve as it travels underneath the skin. Have you seen people like this too?
Absolutely. I think the easiest way to know too is when we kind of just do some wiggling of the skin where that nerve runs through, it can change the pain temporarily. And if it was a joint issue, picking up on skin like that's probably not going to help.
What's skin rolling look like?
I can show you on your arm, or I can show you on your SI joint.
Okay.
There you go. So on the back side here, usually if you're, you have the shoulder mobility to be able to do so, you can reach around to the back side, right where your SI joint is at. And we're going to grab some skin there.
You got cold hands.
We're gonna lift and we're going to wiggle, okay? Or we can kind of do this like, what do we call it? The actual rolling part of it. So what you want to do is you want to go in different diagonal fashions across that joint, and then maybe chase it upward to where we said it originated from. So anywhere along this chain here where we wiggle the skin, not pinch where it's hard, but just kind of getting some lift and some decompression of that area can be helpful.
Yeah, and since I'm here, like that anterior tilt and like the lumbar extension that people tend to have, like look at all the compression that's happening. Like I'm sure like my muscles right now look like little hot dogs back there, right? But now they look a little bit more relaxed. So, but yeah, so a lot of the mechanics associated to all these problems have similarities to them, but the symptom generating structure are just a little bit different.
Yeah.
The last one is the glute max trigger point, or other trigger points actually. I shouldn't say just the glute max, but here is a picture of a book. This is called Simmons and Travell. It's the red book. It costs a lot of money now, but if you look into all the pictures online with all these little dots and so on, you'll see that these are actually just representing referral patterns. And so what they did, I believe the procedure was, is they would stab different areas of the muscle and they say, what do you feel? And people would start pointing at different areas, and the hot red spots are the ones that like most people would talk about. And so the QL has a referral pattern there that you can see in this picture, and you can also see that the glute max does too. I remember I spoke to someone before that, I don't remember if I told you the story, but he had SI joint pain which would flip sides every month or two. And eventually he figured out that that's where he was doing his self testosterone injections. And so he stopped doing his injections and he said, my pain went away.
Interesting.
So, and then you started just changing locations where you do the injection, but like that would be exactly what's happening in this Simmons and Travell model. Yeah. So don't assume that it's always going to be the joint.
Yeah. Trigger points are there for a lot of different reasons, but it's usually your body's way, your nervous system's way of trying to get you to stop moving the way that you're moving through that area. So a lot of this all does come back to movement, biomechanics, a lot of other things in lifestyle choices and habits too. So kind of the takeaway is it's really tricky to try to figure out sometimes what is causing your SI joint discomfort.
Yeah, so now let's get into some like management strategies. I think the first and foremost thing is that if you find something that always bothers it, stop doing that for a little bit. It seems kind of simple to think, but it is really that simple. You can subtract something out of someone's life. Like if you like to do a certain stretch or certain exercise and it always irritates your SI joint, just stop for a couple weeks. And then you can start to reintroduce it and see if it's more favorable to it at that point. The second thing is we can add things, which is adding in exercises or stretches or so on, and that would be based upon the clinical findings that we end up having, such as decreased passive or active range of motion of, let's just say, a hip. We'll also reduce strength of a hip, poor trunk control, inward collapse of the knee as you're doing things like squatting assessments or single leg assessments, excessive anterior toe, which we've already discussed, and poor single leg balance. So if you have a condition like this and you're wondering where to start, maybe start with the one that you're deficient in. And that's the whole value of doing a good physical examination, like getting your telehealth done or having someone watch movements. But let's just assume that I have a limitation of I'm in anterior tilt all the time. Maybe we just cover a couple an exercise for that and assume that I also have poor hip internal rotation.
Okay.
What would you do for those?
For those two things?
Yeah.
Well, we can keep it super simple. I mean, there's many, many ways that we can go about this, which is the beauty of working with somebody is let them help find the one that works for you. But if you lay on your back, we can just go over some simple posterior tilt exercises.
By the way, is it bad to have an anterior tilt?
It's not bad to have an anterior tilt. It's not necessarily a diagnosis. It's just a position your pelvis is in. And everybody's a little different in the degrees of which, the degrees of how much of that position they have. It's if you spend a long time in that position or if you don't find other positions, it's going to end up hurting and causing issues. Real simple, grab your knees, pull them to your chest. As long as we can tolerate this. This is the most easy and passive way to get your pelvis into a posterior tilt. So you'll notice here at the bottom, we're kind of pulling the sacrum up off the floor. That's how we know we're really getting that posterior tilt. So as long as the hips can tolerate this, we can hold this, we can breathe into it. So we can use our belly, our diaphragm to really accentuate that. You can do reps of it if you want to. But doing easy passive stuff like this is, again, temporary relief. We want to really grab the muscles that put you into that position. So what I would do is put your feet back on the floor after we've done a little bit of that to warm you up and start thinking about really pulling your pubic bone towards your face. Exactly. And there's a few different muscles that'll do this. Your glutes can help you do this. We can really cheat by using the feet. Wouldn't call it cheating. It might be just introduction. If somebody really has a hard time getting a posterior tilt, use the feet, push the back into the ground, pull the pubic bone. Just like that. And then another progression to that would be take the feet away, put them up in the air and see if we can now just use the lower belly to pull that pubic bone towards the face. So those are some progressions of ways that we can get into a posterior tilt.
Yeah, and also too, I know that like earlier we said like there's different reasons for the SI joint to be affected. This is more of that non-traumatic level. So if you've been dealing with traumatic stuff, like there's endless things. There could be fractures, it could be. So this is more of like those subcategories that don't really have as much load involved. Okay, so that addresses time into an anterior tilt. So it gives us time into a posterior tilt. And then, but does this really strengthen the core if there's any core issues? Like, so we talked about one of my problems is I'm always in an anterior tilt, but let's just say my belly is weak too. What would you give for that?
I would then flip you over. And just challenge that kind of new position in a different way. So we call this a hard plank. So what I would say is give me a turtle shell. There you go. Everybody's going to turtle shell from a lot of different areas. So we can really turtle shell here if we want to. But we're looking to turtle shell more down here. So getting that sacrum up to the ceiling without shooting the butt cheeks up there into the show them the anterior tilt here.
So this gives a good example of now if I had poor core support, that would be one thing. If I had too much time in an anterior tilt, you're going to give me something for that. But now what if I have that deficiency of internal rotation?
Most of the time, internal rotation of the hip deficiency is improved with hip extension.
Well, why do you think that? Because it seems like it would be second nature just to try to get more range, right? So why would you think that adding more hip extension would help out with getting more hip internal rotation? Because I feel like most people, like when they're starting to do it, they're like, I don't have this, so I'm just going to do it a lot more. Like, why not just start there? Like we just observed that, right?
Yeah.
Adding hip extension tends to unlock hip internal rotation. So I was just teasing on to give more answers. But sometimes the easiest answer is we don't really know. It's just been observed,
Yeah.
right? So
I've just learned from some places that to get hip internal rotation, you need to extend it. You go back to testing hip internal rotation and it gets better. A question of why is a good one.
yeah, I've noticed the same thing with mid-back people. It's like to get more rotation, you just extend them. And
you can add a little internal here with this too. So as long as we can get the hip to extend, kick the foot out to the side of you, there's the internal with the extension. It's just going to loosen up some structures there. It's going to loosen up some ligaments, free up the hip. We'll probably see some improvement.
Yeah, so how long to do these things, again, is based upon each person's individual problem. And also considering, like, what's the intention of the exercise? If the goal is to get the ab wall strong, then maybe you need to do it a lot more than you think. It's like 2-3 days a week. Maybe it's going to take 3 weeks to do it. If you're just trying to expose me to posterior tilt, you kind of did it. Like, it's kind of like his purpose was done. And I would imagine to address a stiff hip capsule, this is probably going to take months, right? So, but it doesn't mean I'm in pain that long. It just means that the intention of the exercise and the reps and doses and so on is based upon what the intention of what you're trying to get out of it.
So all of this stuff is really helpful to start with, to just educate yourself, to maybe try some things to see what you can tolerate. You may notice that trying one of these exercises we showed you gives you some relief. All of that is always just a beginning point though. Most of the time we don't want you spending all your time on the floor every single day doing stretches, doing easy exercises just for pain relief. We want that long-term benefit. We need to start to add some load to the body. So that might look like strength training or resistance training or getting back to sport.
Yeah, and usually that's just, it becomes a habit change. So if you haven't been doing any weight training or any sport, then that's probably something you're going to want to do no matter what age you're at. But as we kind of say, like unless trauma-based, like you didn't get here to this point on accident. This is a sum of your old habits or things that you've been doing. So we have to change some habits too. Adding in a few exercises isn't going to necessarily change anything long-term. So if you guys are looking for help, remember we have telehealth and we have other resources at the bottom, free giveaways and books and webinars that would help you guys get a little bit more insight than just this length of a YouTube video. Watch the video in the corner. It'll be related to this one topic, and we'll see you next time.